So I have the privilege and also a challenge of trying to set a context for how we got to this day. This is, from my perspective, a truly historic day. We have a chance to do something that, as Saint Teresa, Mother Teresa used to say, something beautiful for God. We have a chance to address a systemic, endemic problem in America that really has been lacking leadership. And to do it in our own communities, first and foremost, caring for our own, here in our parishes, in our communities, in our healthcare ministries, in the great state of California, as an example of what's possible nationally and frankly beyond. And we have the attention of the Catholic community, frankly, across this country and worldwide. I want to give you a sense of the depth of the challenge we face, but also, hopefully, how living our values, our deepest core values, can chart us a course to a very, very bright, affirmative future. It starts with a real challenge, a real crisis. In July and August, the Chan School of Public Health at Harvard interviewed 1,500 Americans who were living with serious illness. That's much better, thank you. When they looked statistically, and it was statistically significant responses, people with serious illness said they experienced distress over and above the physical symptoms related to their specific condition. 62% reported feeling anxious, confused, or helpless. 48% have emotional or psychological problems caused by their medical condition. 32% reported feeling left out, lacking in companionship, or feeling isolated. Not truly medically based problem, feeling isolated. You get a sense that this is a true public crisis. This isn't minor. Over the weekend, I also read this article from the New York Times, When the Hospice Care System Fails. Sobering for those of us who are proud of standing up hospice in America. And let me say that this wasn't, although the title was about hospice care, it really was about the healthcare system writ large when you get down into it, and I encourage people to read it. I'll read just the first and last paragraph. Let me start with an apology, Daniela Lamas, who I happen to know. She's a critical care doc at Mass General. When I saw that your 90-year-old father was in our emergency department after being resuscitated while on home hospice, I assumed that I understood what had happened. As a critical care doctor, I have cared for patients whose families have changed their minds at the last minute, grasping on to impossible hopes rather than face the reality of death. She goes on to explain and tell this story, and it turns out that's not what happened at all. This was a family who was trying to care for their father at home, trying to give him the passing to this next life that he wanted. They were prepared. They had met the hospice team at their home, but he had just been admitted. The hospice team had yet to drop off the crisis pack. They had just done 2 hours of the admission bureaucracy and paperwork and getting to know one another. And then that evening, he developed a crisis. The last paragraph is telling, my apology can't take away those memories, but I can hope that when you look back on your father's death, you will see this. You did everything you could. We're the ones in healthcare who must do better. And then we have this. This is the part of what keeps me up at night. We have a growing epidemic of people with Alzheimer's and related dementias. This is the disease of our era, folks. And while we're dealing with the assisted suicide movement, End of Life Options Act now, and dementia is one of the safeguards. You have to be able to understand and take the medications yourself. Already, our friends on the other side of this issue are talking about the safeguards as actually now being barriers to access. Right? This is already part of their narrative. The public can be understood to be confused. They're right to be confused. This is a problem. This is a problem that has grown out of a failure of clinical and cultural leadership. Clinically, I can't apologize often enough for how badly we have been caring for people who are seriously incurably ill, how badly we have been teaching medical students and physicians in training the skills of communication, of listening, of attending to people's feelings, not just their physiology, of accompanying people through the end of life. Culturally, those of us, including in the faith-based communities who have been opposing physician-assisted suicide, have done a lousy job of really leading the culture. The American public knows well what we are against. But as Bishop Van alluded, the American public can be forgiven for wondering what we are for. They are worried about dying badly. They have seen others, the people they love, die badly, suffering as they die, dying in ways they would not have wanted to be cared for, in places that they would not have wanted to be had anybody asked them, but of course we don't ask them. When you look at why people are choosing to hasten their death, this is recent data from Oregon after 20 years or more of the Oregon Death with Dignity Act. Just look, I'm sorry that I made this on a Mac and therefore it's stepping on itself, but the reasons here are clear. It's not physical, uncontrollable physical pain, which is what the proponents of physician-assisted suicide marketed this as. There's some patients whose pain just can't be alleviated, which is not exactly true, but okay. But it's not the reason that people are choosing to end their life. It's loss of autonomy, right? 90.1%, 90.9% over the 20 years. Less ability to enjoy life, 89.5%. Loss of dignity, 75.7%. Loss of control of bodily functions, being a burden to others. Inadequate pain is about 25%. And most recently, 21%. Same as the case in California. Similar to Oregon's experience, the researchers say, patients' end-of-life concerns appear difficult to palliate, with the most common cited reasons for pursuing the End-of-Life Options Act being existential suffering, inability to enjoy life, loss of autonomy. I put this up because look at, if that's the criteria, if that's the reasons driving people, you don't have to be dying exactly to experience that level of suffering. There's a lot of people in our communities feeling that badly. What we're doing here today, what makes this so important is we're trying to assert both clinical and cultural leadership, and that requires seeing opportunity within crisis. That's what I want to challenge you all about. At the Institute for Human Caring and in Providence St. Joseph Healthcare, we see an opportunity to routinize highly personalized care. That's why we're motivated to do this work day in and day out. Leadership will require understanding the right use of language, right? Thank you. When I teach medical students about just the basics of healthcare, I, as well as others, are complicit in using this problem-based language of medicine, right? When you come to a doctor, the first thing that happens, and we teach medical students to do it, is to create a problem list, right? That's the table of contents of a patient's chart. For every problem on the list, we SOAP our notes, it's called. For those of you in healthcare will recognize it. We have subjective information from the history and questions we asked, objective information from the vital signs and our physical examination and the tests that we order. We create an assessment and a plan. That's the SOAP note, right? Everything that we do has to relate to a problem on the list. This is Confucius, who said 2 millennia ago, the beginning of wisdom is to call things by their proper name. As we teach medical students that the nature of illness is problem-based, we cause a problem ourselves. Because if you think something is categorically medical, you're going to bring medical tools to the job of caring. And that's fine, it's just not always the right response. Did you ever try to tighten a screw with a hammer? Right? You can be earnest, you can be well motivated, you can be innovative and creative, you can be persistent. Ultimately, you can get a really big hammer, but it's not likely to work. Not that there's anything wrong with the screw or anything wrong with a hammer, it's just that the tools don't fit the job, right? The fundamental nature of illness isn't medical, it's personal, intensely so. Of course, it contains the medical, it's part of it. People who are seriously ill have medical problems, but the experience, the nature of that experience is intensely personal, not just medical. It's personal for everyone who knows and loves that person. Whenever one individual gets a serious diagnosis, his or her family shares in the illness. Of course they do. We all know that. But in healthcare, in the culture of healthcare, we act through the problem-based model. And in fact, we discourage and actually admonish, an intern or a resident who orders a test or starts an intervention, a therapy with a patient that doesn't directly respond to a problem on the problem list. We're like, why are you doing that? Is it medically necessary? Right? How are you going to pay for that? Right? There's people waiting to be seen. You've got other work to do, medical work to do. It's hard to chart things in your medical record if they're not based on a problem. Finally, in this landmark report called Crossing the Quality Chasm, the Institute of Medicine defined quality. They said high quality is care that is safe, effective, patient-centered, timely, efficient, and equitable. Finally, we had a definition and sort of categories, or what I like to call a taxonomy of quality. This was groundbreaking, and these categories of quality are still being used today. We're drilling down into them, where every medical specialty society is applying them to their specific province of medicine, their procedures, the diagnoses that come to them, and the stuff that they do. Patient-centeredness has to do with the quality of decision-making and decision support. It's healthcare that establishes a partnership among practitioners, patients, and families when appropriate to ensure that the decisions respect patients' wants, needs, and preferences, and that the patients have the education and support they need to make decisions and participate in their own care. That's what quality is. It starts with a conversation, right, about really what matters most to you. The antidote for this is something called shared decision-making, which is that partnership that the Institute of Medicine referred to. It's shared decision-making most plainly means that we doctors come to the clinical encounter, to the therapeutic relationship, hopefully as experts in the diagnosis and the treatment of a patient's condition. But the patient, as a whole person, and the patient's family already are experts in their personhood. They understand their priorities. They understand how their ethnicity and their religious beliefs impact their choices and their quality of life. They understand the idiosyncrasies of their past and their family and what matters most to them. I want to challenge us further, those of us in healthcare. The Institute of Medicine gave us the definition of quality, a categorical taxonomy for quality, for high quality, but didn't they also, in the converse, give us a definition and taxonomy for low quality? Or let's just talk in the vernacular, for bad care? It's treatments that are unsafe, ineffective, non-patient-centered, untimely, inefficient, or inequitable. It's common. Go through any large hospital ICU and you will see patients receiving bad care. And I love ICUs and I love saving lives. I was an emergency physician for almost 15 years. I believe in life-saving power of medicine, obviously. Let me introduce you to the Institute for Human Caring. I have several of my colleagues in the audience today. We are a mighty little team within Providence St. Joseph Healthcare driving quality improvement around something we call whole person care. Everything we do within the Institute for Human Caring addresses and advances the mission, vision, and core values of Providence St. Joseph Health. As expressions of God's love witnessed through the ministry of Jesus, we are steadfast in serving all, especially those who are poor and vulnerable. This promise statement is something that animates those of us who work in Providence St. Joseph Health Ministries. Together, we answer the call of every person we serve. Know me, care for me, ease my way. Now down to why I'm here today. Because leadership is going to require caring communities. You know, in America today, there's really only two ways to get a social problem dealt with or social services paid for. You either have to call it a medical problem, and then insurance or Medicare or Medicaid kicks in, but not always well, or you have to call it a criminal justice problem. Now you can see with wayward adolescents, sometimes it's called a mental health problem, and we've created centers like Rivendell and these psychiatric services and give prescriptions to adolescents, or we call it a criminal justice problem, and they become juvenile delinquents, and then they go through the court system. There's a third alternative. You can call it a community challenge and own this by community. And I can tell you examples across the country of communities that have stepped up to reparent adolescents, to give them the support that they need to be healthy, responsible adults. Similar things need to happen around the care that we provide to seriously ill people in our communities. Here's an ethicist, Harold Vanderpool, a physician, wrote years ago in the Journal of the American Medical Association, being part of a community is essential to the development of consciousness and individuality and is characterized by communication, mutuality, ethical ideals of fidelity, gratitude, reciprocity, justice, and love. Community being part of people being healthy. This is remarkable. We are communal animals. Human beings have little meaning out of the context of our relationships to other people. The Christian ethicist and philosopher Henry Nouwen said, "Our society suggests that caring and living are quite separate, and that caring belongs primarily to professionals who received special training. Although training is important, and although certain people need preparation to practice in their profession with competence, caring is the privilege of every person and is at the heart of being human." I highlight this quote because we cannot think that seriously ill people, including people with dementia, are the province solely of doctors, nurses, social workers, and chaplains. Yes, they need to be involved, and yes, they need to step up their game significantly. But this is something that belongs to all of us. We have responsibilities, obligations to one another. It's part of what makes us human. Lori Zoloth-Dorfman, a Jewish bioethicist, has said, "Cleaving to another, recognizing that the other is the bone of the bone and the flesh of the flesh that is given in common. Locating the mutual body as the site of the moral gesture is fundamental to ethical reflection. It requires a radical rethinking of all that occurs to the other. All of the yearning, all of the loss is in fact my loss. This responsibility for the narratives, great and small, for the dreams of the other, for the temptations of the other, for the responsibility of the other, creates a mutual commandedness. The encounter is intensely personal. The death of the other, the illness of the other, her vulnerability is your own. That each of us will die, Lori says, is inevitable, but what must come to be understood as miraculous is our ability to love and bear the weight of the dying in fellowship." Growing up Jewish, I understood the Abrahamic covenant to bond God to man and man to God, but also to bond people to one another in community. We belong to one another. What Lori is talking about is the notion of a healthy human society in which people are born into the welcoming arms of community and die from the reluctant arms of community. That's what we're trying to do. That's what all of you who work in religious communities, parishes and other communities desire, isn't it? That's why we're here. Leadership is going to require not just better health care, though it needs that, and better support within our communities, though deeply that's needed, but the collaboration of the clinical and community-based services. That's what brings us together. Together with leadership from Bishop Van and the bishops of California, through the Alliance for Catholic Healthcare. I think I saw Lori Dangberg, who's here today, and the bishops of California. We're coming together to take better care of those that we serve, those that we are privileged to serve. We're currently calling this the Whole Person Care Initiative. It's starting where we are, learning our way to effectively move forward. There are people in this room who have been actively engaged in this. Dr. Jennifer Ballantyne is here now with the California State Palliative Care Institute at San Marcos, but she was instrumental in creating this plan for us. This is a remarkable collaboration of all the archdioceses and dioceses in California, along with all of the Catholic healthcare centers and ministries and systems in California, to do a better job, to start to fill in that and answer that question of what we are for. Right? We are for persons in our congregations and communities and hospitals feeling loved, wanted and worthy, and wanting them to be prepared for and supported in their health through serious illness and through the very end of life. This is not too much to ask. This is what motivates us. This is true affirmation of life. Whole person care attends to people in their basic human needs, strives to optimize health, alleviate suffering, bring comfort, and prevent injury and illness, and foster physical, functional, emotional, social, interpersonal, and spiritual well-being. We want people not just to be out of suffering, we want them to thrive, to flourish through the very end of life. Whole person care is applicable through the course of life and is made available through the collaborative efforts of healthcare, social services, congregations, communities in the support of an individual's family and home environment. We're now working with the Archdiocese of LA, the Dan Murphy Foundation, which funds Catholic healthcare, Catholic initiatives. My colleague Ashley Arion, can you wave your hand? And Marlo Morris is helping work with parishes and through the Archdiocese and now here in Orange to develop training programs, to develop resources within the faith communities that link up to the enhanced palliative care and general whole person care in our Catholic health ministries. We're trying to identify leaders within the parishes and the faith community nurses or parish nurses, help train up and skill up both the clergy and religious community as well as the clinical community to how to care better for people, how to have conversations about advanced care planning, how to complete advanced directives, how to make use of palliative care, how to make sure that people aren't getting lost in our faith communities when somebody, because of illness or frailty of age, stops showing up at church, knowing where they are, how to bring communion to them, how to make sure that they don't fall through the cracks, not just in our social services, but in our health care. This is all doable. We got to do it. And lastly, I'll leave you with all of this is going to happen with our sophistication, our technical expertise, but it has to happen with love. Love is the impetus that brings us all here today. It brings young clinicians in training to the healthcare professions. This is not just woo-woo. This is what motivates us all. Remember Avitas Donabidian, the father of healthcare quality improvement. As he was dying, He had prostate cancer. He was interviewed by the leading health service journal, Health Affairs, and he said, systems awareness and systems design are important for health professionals, but they're not enough. They are enabling mechanisms. It is the ethical dimension of individuals that is essential to a system's success, the ethical dimension. Ultimately, he said, the secret of quality is love. You have to love your patient, you have to love your profession, you have to love your God. If you have love, then you can work backward to monitor and improve the system. We have love. It's okay to actively, unabashedly love the people who happen to be ill and our patients, our congregants, right? We have a chance to move beyond the current status quo. I love this picture, of course, we're all familiar with it. Creation is not simply a biblical construct. The astrophysicists tell us that quite literally, creation is still happening. The Big Bang isn't over. It is literally expanding, right? In the social and cultural environments in which we work, in the clinical environments in which we work, we are not simply passive recipients of whatever happens. We can be active participants, constructing a future, creating a future that is based on love, that meets people's needs in ways that are technically, clinically excellent, but also unabashedly tender and loving. We can do this together with creativity, with expertise, but also with tenderness, with love, and with joy. Together, we can make the best care possible. Thank you all for being here. I look forward to working with you in the months and the years ahead. Thank you so very, very much.